In this first module, we will focus on understanding the disease, which is diabetic retinopathy. This is a chronic complication of diabetes. But how does it occur? What are the risk factors? Who is affected? And what are the control measures? These are the aspects we will explore in this module. The hallmark of diabetes is a persistently raised blood sugar. We refer to this as persistent hyperglycemia. Now, persistent hyperglycemia affects many organs such as the eye, the kidney, the blood vessels, and the nerves. Different parts of the eye are affected in diabetes. However, in this course, we will focus on the effects on the lining of the back of the eye, which we call the retina. When the retina is affected, we get diabetic retinopathy. And this leads to vision loss and blindness if it's not treated. The image at the top shows a normal healthy retina. This is the back lining of the eye, and it has small blood vessels which can be identified from this image. Persistent hyperglycemia affects these small blood vessels. They may get occluded, which leads to ischemia and hypoxia. The result of that is upregulation of vascular endothelial growth factor, which stimulates neovascularization. This is the formation of new blood vessels over the retina. These blood vessels are weak and bleed easily. The second thing that may occur is microvascular leakage, and this leakage will lead to retinal edema. All these effects will lead to diabetic retinopathy. The image at the bottom reflects the characteristics of proliferative diabetic retinopathy. And a patient with proliferative diabetic retinopathy is at risk of sudden vision loss and blindness. How many people are affected by diabetes and diabetic retinopathy? We can compare the numbers in 2015 and 2040 in order to identify the trends. In 2015, 415 million adults were living with diabetes globally. This number is expected to rise to 642 million by the year 2040. A third of these people are expected to have some form of diabetic retinopathy. This was 145 million in 2015 and is expected to be 224 million by the year 2040. 11% of people living with diabetes will have vision-threatening diabetic retinopathy, also called sight-threatening diabetic retinopathy. This was 45 million in 2015, and it might be 70 million in 2040. Thus, the number of people living with diabetes is increasing, and similarly, the number of people with diabetic retinopathy is increasing. Thus, we need to develop our services now to cope with these numbers. We also need to implement strategies that can help us control both diabetes and diabetic retinopathy. The control measures for diabetic retinopathy are mainly four. Lifestyle change involves modifications in diet, in physical exercise, and in stopping smoking, among other factors. These help to control the blood sugar as well as to control other metabolic parameters. We also need to monitor metabolic control so that we are able to tell whether we are within the targets. This might be blood sugar, HbA1c, blood pressure, blood lipids, and other metabolic parameters. They need to be monitored frequently. Appropriate treatment is available for diabetes, for diabetic retinopathy, and for comorbidities such as hypertension. We have pharmacologic treatments for those conditions. We also have non-pharmacologic treatments. For diabetic retinopathy, the treatments are laser, intravitreal injections, and surgical interventions such as vitrectomy. Retinal screening is important for early detection of diabetic retinopathy. All persons living with diabetes will require retinal screening so that we can detect diabetic retinopathy before the advanced stages. Most of the programs recommend an annual retinal screen. It might be more frequent if recommended by the doctor. When we examine the retina, we might find 4 different scenarios. We may find that there is no evidence of diabetic retinopathy. We may find that there is evidence of diabetic retinopathy, but it is not vision-threatening. We may find vision-threatening diabetic retinopathy. We may also find that in addition to vision-threatening diabetic retinopathy, the patient has severe vision loss. The focus of care in these different scenarios needs to be considered. In all the 4 scenarios, metabolic control, lifestyle modification, and patient education is important. These 3 apply across the board. In addition to this, those with no DR will require regular screening so that diabetic retinopathy can be identified as soon as it develops. Those who have DR that is not vision-threatening require regular monitoring so that we can identify the progress of the DR. Those with vision-threatening DR require immediate treatment to prevent vision loss. And those who already have severe vision loss require rehabilitation in addition to the treatment for vision-threatening diabetic retinopathy. By the end of this module, you should be able to describe the epidemiology of diabetic retinopathy. Relate the risk factors for diabetic retinopathy to the control strategies. Match the natural history of the disease with the focus of care. Estimate the need for DR services in your own setting, and infer the relevance of a screening program in your setting. We have materials for you that you can use, you can reuse, and you can share as you learn in this course. Welcome to the module, and we hope that you find it useful.